Welcome back to the April 2018 edition of Emergency Medicine News Live. We have some really fantastic articles this month. We have a brief discussion on sickle cell anemia, which is an important type of article for me. I'm excited about that one. We have our emergentology section. That's a discussion on back pain by the unmatched Graham Walker. We talk about some uses for tranexamic acid yet again. That's in our medically clear column via Dustin, Ballard, and David Vinson, and some really critical information on therapies for renal colic that comes via Dan Runde. We're also going to dive into the use of phenobarbital for alcohol withdrawal from our recurring favorite, Dr. Leon Gussow. And obviously, of course, I'm here with my partner extraordinaire, Martha Roberts.
Hey, Rick. How's it going?
Hey.
I think it's super important that we talk about who we have in the background here, who's going to be our foreman, actually, for quite a bit of our conversation. And that's Sergey Motov. How are you?
I'm great. Hey guys. Hi Rick. Hi Martha. Thank you so much for having me.
Sergey, can you just tell me a little bit about what you're doing and where you work for our listeners, please?
I am EM doc from Maimonides Medical Center, which is in Brooklyn, New York. And as far as academic title, I'm a research director, and my passion or interest lies in the area of safe, effective, and judicious ED pain management.
Well, that is really useful for a lot of reasons. And I got to tell you, I took a look at your website. I've looked at your website in the past. I love what you have to say. Not only does your website, and I'm just going to give the address and we'll give it again at the end, it's painfree-ed.com. And there are links to education. There's some really great tweets, which I love reading. There are some great evidence-based practice articles, a full library of information about pain control with a really wonderful focus on different lectures, articles, reviews, and even a section on addiction. So first, I just want to ask you, for our listeners, how did you even become involved specifically with pain management?
That's a great question, yeah.
Well, first of all, thank you so much for acknowledging my website and work. I really appreciate that. I'm going to take you back about 12 years when I was a second-year EM resident. And the concept of one pill fits all didn't really sit well with me. I vividly remember times when my supervising attendings were giving 20 to 30 Percocets for patients at discharge or 4 milligrams of morphine, pretty much for no matter what they had. And I wasn't comfortable with this approach. I started asking questions. Sometimes I was getting some good answers. Sometimes I wasn't getting good answers. Ultimately, I've decided to take the matter in my own hands, start reading, educating myself, and then educating others. And before you know it, now we're having a podcast together.
Well, we're happy that you're here. I certainly can't say there isn't a single provider I've worked with that hasn't had pain as an issue, where we look at the patient and we're like, yeah, what's a few Percocet going to do to this patient? But in this world today, we know it can do a lot of harm.
100% agree.
All right, well, let's jump into our articles. What do you say?
Yeah, let's get into this. I think we have some really great stuff that we should talk about.
We do. Let's throw them right into the fire. There's an amazing article this month, as there always are, by Graham Walker. It's his emergentology segment, and it's talking really exactly what we're talking about here, and that's back pain. So this is a paper written by Graham Walker that discusses the ups and downs that we've dealt with for quite a long time with managing back pain, that it's difficult to get a hold of. These patients come into the emergency department. We try any matter of analgesia. There's obviously been papers talking about the uses of opioid analgesia as compared to nonsteroidal, the use of muscle relaxers as necessary, and it's very simply difficult. And Graham's conclusion of all this is it seems to be that almost nothing works. And it's a difficult conversation to have with the patient. It's very frequently a difficult clinical encounter. Certainly I'd love to hear, Sergey, your approach to back pain, your thoughts on Graham's article, and what we can offer our patients.
Well, article was fascinating with many, many aspects of it. But one of the key points is that I enjoyed reading immensely was that there isn't a quick fix for treating any back pain or any type of back pain or any pain at all in our emergency department. And to add to it, one of the biggest pet peeves when it comes to pain management overall is a necessity to engage patients in shared decision-making about overall goal and expectations. Expectations are crucial. You can't tell patients, I'm going to take your pain away and you're going to be pain-free. That's not the goal. And when it comes to back pain specifically, the goal should be directed towards a functional restoration. If patient comes in prone on a gurney, if you sit him up, you won. If they come in on a wheelchair, you stood him up, you won. If they're standing and you made them walk, you won. Functional restoration. Make sure they can go back to the daily activities. Not the self-reported pain score, not the level of pain. If they're comfortable with it, let them go.
I got to say, though, before you even continue, when these patients come in and they have back pain and they've tried, quote, Motrin, Tylenol, heat packs, all these other different things, and you look at them and you think, how can I get them to that standing position? Because I'm not even sure I can get them to walk. How is it that you do not just immediately want to jump to some kind of narcotic pain relief for them?
Well, then I'm going to reverse it. Let's start with basically no when it comes to back pain. No muscle relaxants, no benzodiazepines, and no opioids. Multiple research data, multiple studies show they don't work. They make things worse, and frankly, they make pain much more prolonged than it would have done otherwise. There are different medications in the oral regimen or parenteral regimen. And let's say if we rule out the red flags, I'm talking about dissection, spinal abscesses, core compression, or hematoma, the majority of back pain are either musculoskeletal in origin or myofascial pain syndromes. Here comes a trigger point injection. Magic thing. People like it. You give them a needle with local anesthetic, they feel great. There are a bunch of topical anesthetics or analgesic that we underutilize in our emergency department. Topical Nsaids, topical lidocaine. At times, although not proven, gabapentin may not work, but let's just put it on the side for now. Nsaids, and we can tell you for sure, if you rotate Nsaids specifically, if naproxen doesn't work, well, add diclofenac. Diclofenac doesn't work. Add ibuprofen to it. Combine 2, 3, 4 different classes of medications, and you may succeed. But before even engaging to it, tell the patients it's going to hurt. You may take 2, 3, 4 days for you to be in pain, but I'll do everything in my power to alleviate this pain to the point that you can move a little better than before.
You know, that's a really good point. I frequently use that phrase, and I didn't use it until just recently, this last year. I would say to patients, you know what, I'm going to try and get you in a level of decreased pain, but I'm not going to get you fully out of pain today. And when you set that expectation, patients seem to want to try harder.
Oh, you're absolutely correct. It changes their expression, their understanding changes. A, you've acknowledged their pain. B, you took time to sit down and talk to them. And C, you were honest. You told them, I'm going to take care of you at best possible way, but I'm not a magician. I'm here to make you feel better. And lastly,
you're a magician.
Oh,
you
no.
really are.
We are. We're all in the same boat, and we're doing amazing things. Lastly, when it comes to back pain, graded physical exercise, aquatherapy, physical therapy, maybe even acupuncture, although some people will probably give me grief for it. But there are good data supporting this use. Non-pharmacological treatments is as important as pharmacological.
So there's a few things here that are really important. Just like you say, truth-telling and talking about back pain is important. If just to simply talk with the patient, that the way to get better is going to involve things including weight loss, involve things including functional exercise. And again, it's going to take some time. I want to drill down a little bit on what Sergey was talking, just from my own knowledge. You had mentioned the use of topical NSAIDs, and you also talked about acupuncture. So I really have two questions. My first question is that about acupuncture. Is this a specific sort of course you've taken for your development of ED acupuncture skills? How did you develop that skill set? And my second question is, when you talk about topical NSAIDs, are you talking about topical diclofenac, topical Ketorolac? What exactly are you using?
So when it comes to acupuncture, I need to make a disclosure. I'm not an acupuncturist. What I do is I do have friends. I know people who do that. And when it comes to acupuncture, I would refer them to it. Maybe I'll live long enough to witness an ED acupuncturist who will be able to come to our respected institutions and do their magic thing. But as of right now, it's just a matter of referrals. Topicals, yes. Topical diclofenac, known as a Voltaren gel or Flector patch. Problem is, people need to understand, which is so unfortunate, that majority of insurance companies would not cover this medication. And that's toughest part. Alternatives, Bengay works for some people not. Some methyl salicylate containing preparation or even menthol containing preparations. Topical lidocaine takes a little while, but there's data that topical lidocaine, like Lido patches, work for acute musculoskeletal pain. Problem. Lidocaine patch doesn't get covered, 5% doesn't get covered by majority of insurance companies. Retail price, $325 for 6. You go to any retail pharmacy store, CVS, Duane Reade, Walgreens, lidocaine patch 4%, $10 for 6. Same analgesic efficacy, same rate of side effects. So that's why I always tell my patients, there is the number, look for lidocaine patch 4%, go and get yourself one. I hope that
Well,
answers the question.
I think it's important to point out, because I have actually had acupuncture myself. Acupuncture, if you have insurance, is typically $50 to $80 in my experience with your copay. There are some prices that your insurance will cover. And of course, I suggest, sort of discussing that with your patient. But if you want to go to a 30-minute acupuncture session, it's about $100. So, that's a lot of money for a lot of people. It depends on how important it is for them to improve. And I say that because there's a lot of value in the treatment of acupuncture, and the data is very clear that it helps with back pain. So you sort of need to talk to the patient about, hey, you can keep coming to the emergency department for these costly emergency department visits, which cost thousands of dollars, or you consider doing something that might actually fix your problem.
All right. I mean, that's a lot of back pain, and a lot to really consider. Again, it's a difficult patient encounter very frequently. And I'll be honest, there's many a time when I'm like, this might be easier by just a little bit of morphine or a little bit of Percocet. But Sergey makes some really good points about the data that really shows very little efficacy of those medications and even possibly worsening. Martha, I didn't know that about the cost of acupuncture. I will freely admit that that's an area that I lack any knowledge in whatsoever. Of course, we hear a lot about Dr. Alexis LaPietra and the Patterson Emergency Department and the work they're doing with ED acupuncture. So perhaps we can get them on in the future.
Yeah, one last thing I want to say about Graham's article is that he talks about telling the patient the hard truths. And that's really what we need to get here, that we need to do the takeaway here. Nobody wants to tell a patient to fix their posture or to stop doing the bad habits that they've been doing. Stop doing the poor functionality that's causing their back pain. So I think the most important thing is to be able to explain to your patient, hey, of course, I can't get you out of complete pain today, but there are things that you could be doing that may help. Weight loss is a very difficult term when we go to say that to patients. So I think it's important to at least address it, because if you're not going to do it, who is?
All right, yeah, totally agree. Well, let's move on to our next article, the article of the month. This is an article on phenobarbital. I enjoyed this article. It's by our recurring favorite, Dr. Leon Gussow.
Listen, I love Leon. I love everything he has to say. But I got to tell you, I really disagree with this piece.
What? You got to be kidding me here. I'll jump in on this. This is an article about the use of phenobarbital for alcohol withdrawal. It's a wildly popular concept in the foam community that really draws off a piece by Josh Farkas on his Poem Crit blog, making a case for the use of phenobarbital in alcohol withdrawal. Dr. Gussow really talks about a recent systematic review on this practice, the conclusion of which being that there's not a lot of high-quality literature out there driving this practice. That being said, there is strong physiologic justification for the use. There's a lot of clinical experience out there suggesting that there's definitely a place for phenobarbital in the treatment of alcohol withdrawal. And I'm going to throw in here real quick, my hospital is out of IV Valium, so I have been forced to move to this strategy. And I'll tell you, I don't think I'll ever go back. I absolutely have had wild success with the use of phenobarbital alcohol withdrawal. I'm a believer, having been forced to do this because of the recent drug shortages, and I have had nothing but success, seen fantastic outcomes for my patient, and I think this is an outstanding practice and an outstanding article by Dr. Gussow.
All right, well, I certainly I'm going to have quite an argument with you about this. I'd love to hear what Sergey has to say about this as well, because he is our pain management expert. And I think that withdrawals certainly incorporate a large amount of pain during their withdrawal. But there are a couple of things that the listener doesn't really know yet about the article. So I just want to point out a couple of things. Leon discusses the use of phenobarbital. Now, phenobarbital is something that's been used for many years. Way back when we didn't even have drugs treating withdrawal symptoms for patients, we were using things like bloodletting and just rest, as he kind of comments here. But phenobarbital is a dangerous drug in a lot of aspects, in a lot of ways. Now, I want to just point out one thing. If you're going to phenobarbital, that means that the benzodiazepines that you were using weren't working very well. And when you add phenobarbital on top of multiple doses of benzodiazepines, you're putting your patient at risk for a respiratory compromise or demise. I personally feel the dose that is talked about here, the 10 milligrams per kilogram in the article as an IV loading dose of, if you're going to even go to phenobarbital, is too much. And I would not recommend that. So let's first ask Sergey, if you're going to go to phenobarbital, if that is the choice that you're going to do for these DT withdrawals, what would be more of an appropriate dose, and how would you manage this patient?
So the article itself is fantastic, and I do see both points of view on both sides. And as you all agree, the traditional treatment is benzos. Majority of studies, majority of EDs in the country, they still go to benzos as a go 1, go 2, go 3, and all protocolized, and people are very comfortable with benzos. Phenobarbital, as you mentioned, Marta, it's century-old drug and has a fairly good pharmacological, pharmacodynamic explanation why it's such a good medication when it comes to a severe withdrawal or benzodiazepine-resistant withdrawal. I don't have as much as experience as Rick does. We do have shortage of Valium, but then we basically start using lorazepam over and over and over again. In my opinion, the situation when I've used it, for some reason I observed paradoxical worsening respiratory status when you give too much benzos in comparison to phenobarbital. 10 milligram per kilogram loading dose might seem to be large, but we're talking about relatively young and healthy people who, besides an alcohol abuse, don't really have anything else on board. So they're not really, not suffering from severe COPD. They're not really morbidly obese, although some may be. They're not having sleep apnea. So some of the things that may be not as worrisome for us with respect to side effect of phenobarbital. But from practicality, look, it's a medication with a wide therapeutic window, has a long-lasting effect. And when it comes to monotherapy, I don't believe benzos do as much good as phenobarbital when it comes to monotherapy. And personally, once again, for benzo-resistant alcohol withdrawal or severe withdrawal, if you use monotherapy with phenobarbital, you'll be much more successful. And data, even in systematic review, as Rick pointed out, and different data shows that by using phenobarbital alone, or even with benzos, you can decrease length of stay in ICU, decrease rates of intubation, and frankly, recovery is much, much faster.
I think that there's some really good points that you guys gave the same, I think, very good point, and that was the concomitant use of benzodiazepines. And I think that's an incredibly important point, and I 100% defer to you on that, Martha, that if a patient's getting large doses of benzodiazepines, then that patient is probably not super appropriate for a large dose phenobarbital load immediately following. And there's actually an important point, is that this is a little difficult to parse out because Dr. Gussow's article itself is highlighting another article within the foam community by Dr. Farkas. And within that Dr. Farkas article, there is in fact distinction of, hey, perhaps patients with multiple benzodiazepine loads are not appropriate for phenobarbital loads. And I'm there with you 100%. I'll tell you that my hand has been forced largely due to the benzodiazepine shortage, and my practice is that 10 mg per kg phenobarbital load. However, if the patient has received benzodiazepines either by the residents or by EMS prior to arrival, I will go with 130 to 260 milligram lower additional doses, and that's my practice. I'm right there 110% with you, Martha, that we always have to do no harm first, and the last thing we would want to do is have that sort of double GABA action where we're just going to zonk this patient and make them stop breathing. That would be a disaster. But I will say that in my experience, it echoes what Dr. Gussow is talking about, what Dr. Farkas's article is talking about, and what Sergey was mentioning, is that this medication helps me get these patients home.
Okay, so I hear what you both are saying, and I totally agree that phenobarbital is something that maybe we could do. The problem is that I just had a patient that probably actually maybe would have done well with phenobarbital with his withdrawal symptoms, and that is because, 1, I knew the patient. 2, the hospitalist knew the patient. 3, we knew immediately when he came in this was going to be a withdrawal issue. So this is a guy that comes in with really bad leg ulcerations, and he's gone through multiple treatments for his DTs. And he's really been unsuccessful with benzodiazepines. So in that particular point, I'd say instead of giving this guy any benzos at all to begin with, let's just give him phenobarbital. So that would make sense to me. I just want the listener to understand that phenobarbital is an old drug, that we understand what it does. It's a little different than what benzodiazepines do. However, at the end of the day, if your patient is this sick and very bad DTs, What you need to do is put them in a medically induced coma and give them levels of phenobarbital with an intubation that will allow them to recover. This isn't something that I feel we can just use willy-nilly. And I'm not saying willy-nilly like that's what you're going to do. I'm just saying that
I got phenobarbital darts loaded up. I walk around the ED.
you just really need to know what you're getting into if you decide off the bat that phenobarbital is what you're going to do. And that's all I'm going to say. It's not a bad drug. It's not a bad decision.
No, your words of caution are 100% appropriate. You speak from experience. You've seen things go wrong. I think that you're making very good, excellent points that willy-nilly utilization of any medication, overabundant utilization of any FOMED recommendation is reasonable. I think that I have a vote here for anybody listening to this. If you want to give it a try, go ahead, do it. 130 milligrams of phenobarbital for a patient presenting with alcohol withdrawal is a homeopathic dose, and it's going to work well for your patient. But I echo what everybody's saying here, that giving the patient 20 milligrams of Valium and following it with 1,000 milligrams of phenobarbital is probably the wrong way to introduce yourself to the use of phenobarbital.
Well, be prepared to send that patient. Well, be prepared to send that patient to the ICU regardless of what you do.
Or the morgue.
Yeah.
All right.
Anyway, moving on, because I feel like we could talk about phenobarbital for a very long time. I just think it's important that people actually understand that it's maybe something they can incorporate into their practice with caution. Speaking of incorporating things into your practice, I feel like this is totally all on the same ball of everything we've been talking about in the past. Let's talk about our medically clear article. TXA being superior to packing for epistaxis, and patients like it better. I couldn't agree more with this. This is a piece by Dustin Ballard and David Vinson.
Yeah, so this is they start this article off with kind of a case report, a patient who came in with severe epistaxis, and they treated the patient with TXA. They cite an older study to justify its use, which, to be honest, is a little odd. There are, in fact, newer studies recently published in Academic Emergency Medicine, for example, that support this use. And I got to be honest, my response to this article is not everyone already doing this? Is there anyone out there who has not incorporated topical TXA into their management of epistaxis? Because please tell me that's not the case. I mean, it is. I mean, come on. This is something that's kind of been known for a while now to be incredibly effective. Much nicer to the patient than shoving a Rhino rocket up their nose or putting a balloon behind their nose. I think if you haven't incorporated TXA topically for treatment of epistaxis into your practice right now, I do feel confident in saying you're a little behind the 8 ball.
Sergey, do you want to talk about your experience with epistaxis?
Yeah, I wholeheartedly agree with Rick and with you, Martha, that it'd be hard to find one single ED physician who probably wouldn't try TXA, at least as an initial modality of stopping hemorrhage from epistaxis. I use it on a daily basis. This is my go 1, go 2, go 3 medication. And as far as the rate of success, I'd say about 85 to 90% of cases. Those patients who have multiple, newer oral anticoagulants and concomitant, it might be a little trickier, but regardless, I always try with the TXA. It's highly effective with respect to reduction of the bleeding or complete abolishing of it or prevention of the recurrence rate. I would strongly encourage everyone to use it, and that's pretty much it. That's what I have to say.
I do use it. I see a lot of the nosebleeds patients. The one thing I would like to add is that it's not just simply TXA, and I feel like when people hear about using TXA or they're new to it, they typically say, okay, well, I'll shove a little TXA up there. But my concoction is take the little cup, add a little Afrin, squirt the Afrin into the cup. Squirt a little bit of the lidocaine with epinephrine into the cup, and then add the TXA. Shove that on the cotton ball up into the nose, and that is a wonderful concoction of I need the nose to stop bleeding now.
I think that's so good. All the vasoconstrictors.
Yeah, but part of this article really, what I want people to focus on is that this patient that was talked about, and when you get the copy of EMNews, you'll read about this case. I mean, essentially, these patients can do very poorly. They can bleed a lot, and they can turn pale and code. So if you don't act quickly, if you're just kind of squirting some Afrin up there hoping for the best, that's not going to be enough. Why don't you act a little bit more, proactive, and see if you can get this bleeding to stop earlier rather than later, because especially patients with anticoagulants are going to have a problem.
Very good point. I was wondering if any of you have experiences of combining intranasal TXA with intravenous TXA in order to control epistaxis. Yeah.
It's funny you say that. It's funny you say that. So, and I've just been sitting here thinking about this case I had like 2 weeks ago, where a patient came in with sort of the standard little twiddling nose bleeding, and we shoved some TXA up in there as is my practice, and I expect it to work, and it didn't work in this patient. And that patient got worse, and a few minutes later, we realized it was a posterior bleed, and the patient began to exsanguinate, and the patient needed some posterior packing and actually needed intubation. And that patient got IV TXA from me, and I think that that IV TXA helped run the ball into the end zone and make a difference. I haven't used it routinely in anterior bleeding. I'm not shy to. I think that that's perfectly appropriate. But that's my only experience with using IV TXA. It's been with posterior epistaxis. All right, well, let's go ahead and move on to our next article. This is the one that I was really particularly excited to talk with Sergey about. And this is, I think, really just going to be fantastic. This is our Myths in Emergency Medicine segment. This is an article by Dan Runde, who really just puts out some really fantastic stuff. It's called Rage Against Renal Colic. Keep the Ketorolac, maybe morphine, and leave the lidocaine for last. It's obviously another fantastic article. Tackles a lot of the evidence regarding a lot of the options we have for pain control and nephrolithiasis. There's some great pearls here, right? There's a discussion of a Cochrane review that shows that Nsaids are just as good, if not better, than opioids for pain control in the setting of kidney stones. There's less adverse effects. You need less rescue medication. Really interesting, though, I didn't know this. Dr. Runde points out that the comparator opioid in these systematic reviews was Demerol, and I think I've used Demerol once in my life, so that may not be the most representative comparator of the opioids that most of us are using in the emergency department. And there's a lot of discussion in this article about Ketorolac, how to use Ketorolac, about the analgesic ceiling of Ketorolac, and very fantastically they cite our own wonderful guest here, Dr. Motov. And then there's a brief touch on the use of IV lidocaine, and therefore I can't think of a better place right now to hand over the microphone to Sergey.
I agree with you. So article was fascinating, and it's basically nicely summarizes what we have on the market when it comes to renal colic. I'm not going to go too much into details, and because we'll be speaking till Christmas of next year. But the point being is that we all seen people suffering from renal colic pain, and it's truly debilitating. So the entirely effective and efficient analgesia is the utmost important of controlling pain of these patients. One thing I think it's very important to emphasize that people need to understand why people are having pain from renal colic. And it's threefold. Obstruction, there's a rock sitting somewhere within the ureter or renal pelvis. There is an increase in pressure within the renal pelvis or ureter, and there's an inflammation and ureteral spasms. So if we're going to use this as a basis, and from pathophysiological approach, I'm going to go in order of preference what medication we should consider using. And Nsaids are the Nsaids. These are the go-1 drugs, and regardless of Demerol or not Demerol, they do work better than opioids. Why? Because they inhibit prostaglandins and they relieve ureteral spasms. We use Ketorolac in the United States. Rest of the world is using diclofenac. It can be given intravenously, rectally, and intramuscularly. When it comes to intramuscular route, I want people to understand that it takes a while before medication kicks in. We can't afford people with renal colic to sit for 45 minutes and wait before medication kicks in. It's painful when you give the injection, and about 25% of patients don't respond to IM injections. Problem with Nsaids, they're not titratable. I'm a big proponent of titratable analgesics. You know what you're giving. You go in increments until pain is optimized. Nsaids, you give one single dose and you're kind of done. And after you had 6 hours before next route is available. Another limiting rate of factors is that subset of patients with congestive heart failure, chronic renal insufficiency, active peptic ulcers are not really eligible for Nsaids. And as you mentioned earlier, analgesic ceiling. For the short-term analgesics, it's important to know that 10 milligrams is probably what it takes for Ketorolac to kick in. But having said so, from pathophysiological point of view, there are the ones. Now, the article didn't mention much about intravenous acetaminophen. I'm not going to spend much time on it. I'm personally against it because the exuberant acquisition cost of this medication, it's prohibitive. However, on case-by-case basis, when patients are either allergic or unable to tolerate either opioids or Nsaids, we might resort to IV acetaminophen. Good to emphasize that rectal form and oral form work just as well. The only difference is that intravenous form kicks in a little faster. Lidocaine, from pathophysiological point of view, great medication. Blocks sodium channel blockade, which translates into alteration of erythral tone towards relaxation. 1 case series, 2 randomized controlled trials, not enough data to make assumption, neither refute or support its use. We need more data. We need more data on patients who are older than 65, patient with pre-existing heart disease, or patient with arrhythmia. So as of right now, if you're comfortable, you may try, but know the limitations. Protocolize everything. Don't start pushing lidocaine to people. You may get in trouble. Now, interestingly enough, there's another medication that nobody talks about in America. It's Ddavp.
Oh, I got to hear this.
Whoa,
all right. Big alert here.
Marta, if you allow me, very quickly.
I got to hear this, yeah.
Yeah, it just so happens that our colleagues from Iran and Turkey, they love Ddavp. The way it works, it's antidiuretic, which means less load on the kidney. It's antispasmodic. It relaxes ureter. And lastly, it's actually potentiates endogenous opioid system, beta endorphin. So you can have like opioid-like effect. So it works. Problem. As a single entity, it works in about 40% of patients. So best way to do it, combine with Nsaids. Limiting factor is uber expensive. The intranasal Ddavp at 40 microgram per nostril, it's close to $1,000. So right now it's in America, but I'm talking, remember I mentioned our colleagues from overseas, so their cost is obviously not an issue. So we have Nsaids, acetaminophen, lidocaine, Ddavp on the side. What else we left with? Opioids. Inexpensive, titratable, reversible, but in my only practice, I like combined medication, and Rick knows why. So my go-one would be Ketorolac, go-to or combination is lidocaine. I'm very comfortable with lidocaine. We've been using lidocaine for over 5 years and such for properly selected group of patients. And if everything else fails, I do resort to morphine. If opioids fail, then of course, ketamine. So that's in short when it comes to renal colic. I hope I just put in perspectives. But I believe Nsaids, plus minus lidocaine, plus minus rescue opioids. I think this is the way to do it. Same as the article basically talks about.
Well, honestly, I'm a little bit floored. That is,
I'm blown away over here. That was a masterclass in kidney stones. Yeah.
But honestly, though, I totally think that what you said was a fantastic summary. What is even more important is the dosing. And I think that people don't understand this. And this is part of what Dan goes into in his piece. In the past, we have been giving 30 to 60 milligrams of Toradol. Let's just talk about Toradol for a second and the dosing. We don't give 30 to 60 anymore, IV. It's not indicated for the ceiling of pain effect there. It's not needed. I typically start with 15 milligrams IV, and the literature supports that is 10 to 15 milligrams is about enough to get the same pain results as 30 to 60. So we're going to stop using, if you haven't already, 30 to 60 milligrams. And in fact, if you want to give a shot of the Toradol, 30 is your max.
Well, I totally agree that just like Sergey's own research has shown an analgesic ceiling of 10 milligrams of the Ketorolac, it has for a long time been my practice of 15 IV, 30 IM, because that's kind of a little bit of a holdout from that half dose IM. But I recently discovered from one of our guests' Twitter feed here, and I had no idea that there apparently is no indication to double that dose for intramuscular administration. Is that true, Sergey?
Yes, it is. And once again, I do have aversion to intramuscular injections of any sort when it comes to pain management. It's just the concept of relieving pain by inflicting pain doesn't really sit well with me. Out of sheer curiosity, have you ever had any Ketorolac given to yourself? Have you ever?
I have not had Ketorolac.
No, but I got to argue with you there, Sergey. I love you, but I have read the studies about people who get shots versus oral medication, and the studies show that people who the people who get a shot have better pain relief than those who get oral medication.
The placebo effect of needle, it's excruciating.
I know, but they say they don't want it, but the studies, I'm telling you, I've read them. It's very interesting to read that when someone gets a shot, they think they get better care and better pain relief.
Right, but you know why it happens? Because a provider who actually goes forward and administers the shot, doesn't take enough time to spend with people and explain why shot would or would not work. And contrary to it, there is a fair amount of literature that clearly state that there's no difference with respect to analgesic efficacy between 60 milligram of intramuscular Ketorolac and 800 of ibuprofen. One thing to point it out, that both medications given in their super analgesic saline dose, which shouldn't happen in the first place. But there is a data, to your data, that there's no difference between IM and PO. When it comes to renal colic, these routes should not be used. We're talking about people with renal colic who are ready to climb the wall. And you look in something within 10 to 15 minutes will provide appropriate relief. That's why titratable medication are useful.
You're right. And I totally agree with you when we're talking specifically about renal colic. It's a little bit of a different game.
All right, so just to sum that up, because it was profound, right? Obviously, our go-to here, as you're saying, is the use of Nsaids, and whether that be 400 to 600 milligrams of ibuprofen orally, whether that be 10 to 15 milligrams IV Ketorolac. Okay. Moving on then to lidocaine, and I agree with you that there's some differences in the acceptance of this throughout the United States at this time. There's going to be different levels of comfort and familiarity with this medication, and awaiting a certain amount of protocolization is totally reasonable. And then, before that you had mentioned acetaminophen, and then moving on to your titratable opioids is 100% fantastic. I'd never heard about Ddavp for the use of kidney stones before. Literally have never before, and that's fantastic. I'm going to have to read about it, and I really appreciate all that. I think that's incredible. I am going to move us on in a similar vein, because we talked a lot about Nsaids just now, and I want to talk about Nsaids just a little bit more to our last article. This is from our EMED Home segment. It's the 3 things you should know about sickle cell disease. I really want to sing this article far and wide, because I think there's a lot of really important pearls here. The first is stop using Nsaids. So for how long have people routinely used Nsaids in the treatment of patients presenting with sickle cell crises? You got to stop using Nsaids in the setting of sickle cell crisis. These patients have renal microinfarcts, but almost by definition, and this leads to a very falsely reassuring creatinine and a falsely reassuring GFR. Minimizing nephrotoxins in a patient presenting with sickle cell crisis is absolutely critical, and that's one of the first points brought out by this EMED Home article that you can read in Emergency Medicine News this month. There's some talk about stop using isotonic fluid boluses. How many times have I seen the patient comes in with a sickle cell crisis, and the first thing I see people do is give them 2 liters of IV fluid despite them being euvolemic. The data is overwhelming that this is bad. It increases mortality. It increases acute chest syndrome. Stop routinely administering IV fluids to the patient presenting with a sickle cell crisis. We should be using hypotonic fluids very gently. There's a thought that possibly this hypotonic fluid administration can cause a de-sickling of the red blood cell. Now, I'm gonna throw some caution there that there's some data that suggests that maybe that's not the case either, but certainly we know that we can stay away from IV fluid flooding of these patients. That's old medicine that we can all move away from. And then finally, a pearl that sometimes we all perhaps forget, but an important one, is not to forget about exchange transfusion. It's not just for acute chest syndrome. Exchange transfusion should be considered in all patients who are presenting who are critically ill. But those are 3 things that we need to remember. But that brings us to the next question. So we're not using nephrotoxins, we're not using IV fluids, but these patients are in quite a bit of pain, and they're often very resistant to opioid pain medications. And that brings us right around again to our pain control discussion that we've been having.
When it comes to sickle cell, this is probably one of the hardest pain syndrome when us as the ED docs, clinicians, and practitioners are faced on a daily basis. And the reason being because the disease itself, it's fairly debilitating. People do suffering. And as we all know, but 90% of cases, those patients have difficulty with establishment of intravenous accesses. And lastly, they truly refusing to take any other medication other than hydromorphone, known as Ballard. So we are challenged, and it's been like this for years and years of practices. The question is, what do you do? So when it comes to opioids, it's still considered to be the cornerstone of management of sickle cell disease, and this is one of the pain syndrome that I am open to discussion when it comes to an opioid, with few caveats. Let's say a triage, what can you do? Nebulize morphine. Let's say you have no accesses.
Did you just say nebulize morphine?
Back up. Nebulize morphine.
Right. Let me just elaborate. Imagine the classic sickle cell patient with occlusive crisis, suffering, no accesses, multiple attempts on central lines, and they're just in agony. So let's start with least invasive and we move to more invasive. So we can use nose and we can use mouth. So nebulize morphine. 10 to 20 milligram, fixed dose. 20 works better than 10, up to 3 times. You can start at a triage. It will give you enough time to either bridge it until you manage to establish definitive access. Frankly, you may actually alleviate pain to the level they'll be comfortable. You're not comfortable with morphine, less the fentanyl. 2 to 4 mics per kilo. On adults, it's about 300 mics of fentanyl via nebulization. Up to 3 times titration every 10 to 15 minutes. It does work to the level that patient may feel a little better. So you can get them into the room and you can give them at least some time for you to recuperate and figure out what you're going to do. You don't want to use nebulized fentanyl? Fine. Intranasal fentanyl at triage. You hate orifices? Rapidly dissolvable transbuccal fentanyl. 100 mics or 200 mics single tablet. Put it under the mucosa in the cheek. Dissolves in about 5 minutes. They should feel some relief. I'm not measuring. We ask him how you feeling. They should feel slightly better.
Listen, if you could see, I'm sorry, but my mind is blown right now.
Totally blown. So once again, nebulized morphine fentanyl, intranasal fentanyl. Moving along, subcutaneous morphine, which has actually been proven to work almost as good as intravenous with less significantly painful sensation. Once again, this is very important. This part is very important. Besides putting personal aversion to IM injections, repetitive intramuscular injection of opioids to patients with sickle cell disease leads to aseptic necrosis, septic necrosis, and lastly, myofibrosis, which means they will need to escalate their dose to the level that those tiny little remnants of the vessels that now in the connective tissue will be able to absorb that residual of an opioid. It leads to dose escalation, higher the dose, higher the side effects. So IM route should not be used for people with sickle cell disease. These are the options when you don't have vascular accesses. You have vascular access. Here comes ketamine, sub-disorder dose ketamine, bolus and continuous infusion, and as an adjunct to ketamine, lidocaine, and my favorite, dexmedetomidine, known as a Precedex. A single dose of 6 to 8 mics per kilogram, there's just dose, and 0.1 to 0.2 mics per kilo of Precedex added to ketamine. In 2 case reports, alleviated sickle cell pain almost entirely. Patient was able to go home in 12 hours.
Wow.
After continuous infusion. So all of a sudden, I have this frame with opioid, non-invasive, least invasive or invasive modalities, and non-opioid, such as ketamine, lidocaine, and Precedex.
Oh, I mean, that's all I think really fantastic information. I really want to highlight what you said about the avoidance of intramuscular injections in sickle cell disease patients more than any other group of patients. I can't agree with you enough. I have seen again and again that really sad outcome of avascular necrosis. I've seen what repeated intramuscular injections can do, particularly in the sickle cell patient, and it's just simply not very good medicine. I've never given nebulized morphine. I've never done it. It makes perfect sense. Certainly, I've given intranasal fentanyl several times. It has been I've been wanting to try pain dose dexmedetomidine for patients. I've not had the opportunity or indication as of yet. And I think you make a really good point, framing a number of different options from least invasive to most invasive, just growing that analgesic toolbox in these patients who have very real pain. And I got to really take my hat off, to your expertise in the management of these patients who are very complex pain syndromes, and also to our specialists at EMED Home for providing this very important and provocative article to making sure that we're providing the best care to our patients with sickle cell disease.
And on the last note, I just wanted to emphasize that this is one of the most important parts, to really spend your time and talk to a patient with sickle cell disease who's suffering from vaso-occlusive crisis. It takes about 3 seconds to write somebody for hydromorphone, IM. It takes about 30 minutes to have a normal conversation with a sickle cell patient to explain him rationales of opioid, non-opioid modalities, giving the alternative routes. And this is very, very important. Not everybody is ready. Time is precious, I understand. But if we all follow the common goods for the patient, I think this is the way to do it.
Definitely agree with you there, because in the end, that patient, if they don't get that time with you, they're just going to bounce back another time. They're not going to listen. Things aren't going to be done in the right way for that patient. And when you spend that time, first and foremost, it basically alleviates future visits, future problems. One other thing I just wanted to comment on was that these patients that come in, and you've known them for a long time, they have chronic pain issues, and you think to yourself, and I'm not going to say that this is what happens every time, but I know there are people out there that have this bias And we have talked about bias before for these patients when it comes to pain control. You think to yourself, oh, it's Mr. Smith again with another sickle cell crisis. I don't want to give him narcotics this time. I don't want to go through this whole routine with him. I don't want to do this. I know you all are listening, thinking in your brain, you've done that. I've done that. We have done that. Think to yourself, you know what? Got to talk to this patient. We got to come up with a better plan. And you can't just be ordering an Nsaid thinking that that's going to fix the problem, because A, it's not going to relieve their pain in all occasions. And B, that 30 minutes that you spent whining in your own brain about Mr. Smith being back again, you could have just had that conversation that Sergey just suggested.
Totally agree. Absolutely agree.
So let's sum up what we've learned today, because I think our brains are very full. I can't remember the last time my brain was this full, so thank you so much. First, I want to point out again about Sergey's website. Pain is a problem. The issues with treating pain is a problem, and you need to be well-versed in this. Check out his website. It's painfree-ed.com. You will not be sorry. You will learn all about the treatments for pain, and wow, nebulizing narcotics blows my mind. Again, we're going to have to look at the data on a lot of these things as they grow in more popularity. But great idea. Speaking of pain, let's talk about back pain. Graham Walker's piece is an eye-opener of being #truth with patients, and also coming up with some real ways to explain to your patient how we're going to deal with your pain. Then when it comes to talking about hard truths, well, our patients with withdrawal and DTs, they're going to be too out of their minds to discuss with you what their plans are for recovery. So whether you use phenobarbital or not for these patients is going to be a difficult decision. And we understand that's going to be difficult. So look at your patient, know your patient, and see if it's the right indication to give phenobarbital. Finally, TXA, well, we cannot argue that TXA is a wonderful medication, and we suggest a good cocktail of that for epistaxis. I cannot imagine not combining that medication in my routine right now. It saves the day.
A lot of, I can't agree with you more that this has really been an action-packed episode more than anything. I'm taking a lot away from this that I agree with you. I'm going to read more about, educate myself, and try to grow more in the literature. I can't say thanks enough to our special guest, Sergey Motov. I can't say thanks enough to our incredible emergency medicine news writers who every month give us really so much to think about, so much to talk about, and so much to keep us on the front line of emergency medicine. So really, listen, that's it. We're on our way. We're out the door. We're back to the department to bring the lessons of EMN Live and the writings of emergency medicine news to the desks of emergency physicians and the bedsides of our patients. Sergey, thank you so much for joining us.
Thank you.
Martin, Rick, thank you so much for having me. I had a blast. Thank you, guys.
All right, guys. That's
Until next time, guys, this is EMNews Live.